Good afternoon, everyone. My name is Dr. Lisa Tartaglia,
Dr. Sarah Bohn.
and we're here today to talk about dreaded medication statements. This is part of our serious illness series, and we just wanted to discuss some statements that you really do not want to hear from your healthcare provider.
There are some things about medicines that when your doctor says them, you're thinking, oh, that's not good. And you're right, it isn't good. And if you hear some of these things, it may indicate that your illness is progressing and your disease has become more serious.
Yeah, so we're going to discuss basically three things that we've pointed out, and please feel free to add additional things that you may have heard from your physicians, our healthcare team. But one of the statements that we find quite common that we hear from patients of chronic illness is they need more medications.
Mm-hmm.
Patients with chronic illnesses may need more medications because their ability to treat the symptoms their symptom burden has increased, and their body has weakened as their disease progresses.
Or the same medicines just aren't working as well as they used to. And, many diseases we don't cure, we treat and we care for them. But like with blood pressure medicine, it's not like an antibiotic. You take your blood pressure medicine and then your blood pressure's fine after that. You have to keep taking it because without it, your blood pressure will go up. So it treats it, it doesn't cure it.
Mm-hmm. Several reasons you might find different dosing is the ability to metabolize the medication and even genetic predisposition. Some medicines work well in some people and they don't work well in others, especially with blood pressure medications. I find in my population what works for one may not work for others. But when we're talking of diseases and diseases that are most concerning, meaning somebody that has on antihypertensive medication, so patients that have hypertension, if we're adding more medications to that should be more concerning to you.
It may not be that the medicine doesn't work anymore, but it's advanced and now you need more medicine to manage it to the same degree, to manage it to the same level. And so that's why when somebody's maybe in their 40s or 50s, they may take one medicine, and then when they're in their late 50s or 60s, they may need two medicines, and then when they're, older, they may need three medications. So as that disease advances and progresses, you may need more medication to get the same effect. It's not that you've become immune to the medicine and it doesn't work anymore.
Right.
It's you need more to manage it.
Yeah, diabetic patients kind of fall under that category. And then I like to always talk about our water pills, right? A lot of times our elderly population are taking water pills and they don't even know the significance of them. They are diuretics. They're used for congestive heart failure. And if you're having to titrate or make your water pills into higher doses, that means that your heart is not functioning well. And that is not a good indicator. Yeah. That is a very poor indicator and poor prognostic sign. When we're talking about medications, there's a word that a lot of times people hear of. It's called polypharmacy, and that's defined as anyone, the definition is taking more than 5 medications. Now, that does not mean medications that are prescription strength. That means any medication. So multivitamins could fall into that category, vitamin B, vitamin D. All these kind of things can fall into a sleeping pill. Maybe you take allergy medicine every day. In nursing home patients, it's nine
medicines. And that Tylenol, laxatives, supplements, all of those count in those 9 medications. And if you've got somebody that's got a couple of disease states, maybe they've got blood pressure problems, maybe they've had a history of maybe a heart attack or a little TIA, maybe they've got some chronic obstructive pulmonary disease and diabetes, it's really pretty much impossible to get them under that 9 medication list. What if they've got heartburn and indigestion? That counts as another med.
Yeah.
And they all can interact with each other. As we age, our metabolism may change, our ability to metabolize those medications may change, maybe our absorption changes, the distribution, because maybe our fat to muscle ratio is different, the protein in our blood may bind some of those medications, and if we have less protein, maybe those medications have more free medication present in our bloodstream, so that it's all very dynamic.
Yeah, and they're all interrelated. As palliative physicians, it's our job to deprescribe, meaning to try to eliminate medications that are unnecessary. But as Dr. Bohn said, that's almost impossible, because if you look at somebody that has more than one chronic illness, they're definitely going to have about 2 medications per chronic illness, and most of our patients have 3, 4, or 5. The major problem with polypharmacy is that every medicine has a side effect, and we call that the double effect.
So you've got the good effect that you want, but then there may be side effects that you don't want, that are really kind of undesirable. And so sometimes you have to let the patient know what those side effects are, because they are, part of this, and they get to choose. Those side effects are undesirable for me. That's not acceptable for me. You've either got to find something else, or I'm not going to choose to treat that. And we have to allow patients to make those choices. It's our responsibility to tell them the risks and benefits of whether it's the medication or treating or not treating an illness, so they can make an educated decision as to how they want to proceed.
Yeah. One of the examples I like to talk about with the double effect is our hospice medications. I know this is not a hospice video, but we are hospice and palliative medicine physicians. So a lot of times our hospice comfort medications get such a bad rap because they do cause sometimes more sleepiness, more harm per se, less wakefulness as we're symptom managing. But what you have to realize is I always try to educate patients and families that when patients are more comfortable, they are able to rest easier, and in turn their body will be able to shut down. It's not the medication hastening the dying process, it's the disease being able to take over and the patient's able to rest, because oftentimes it's inherent that the body wants to be in the fight or flight to live. It's easier to live than it is to die.
And when we reach those last few moments and minutes of our life, we want our loved one to be comfortable. We don't want to hasten the end of life. We don't want to sedate them through it, but we do want them to be comfortable. And so if you're struggling, you're in pain, you have symptoms that are not being well managed, that's not a good, peaceful end of life. You want them to be comfortable. And if they're comfortable, they may be sleeping. I know that if I'm uncomfortable, it's really difficult for me to sleep. If I've got a sinus headache, I feel restless, I toss and I turn, I can't breathe through one side or the other, and so I'm restless. And restlessness may be all that they have. They may not be able to say, hey, I hurt or I'm uncomfortable. You may just see that they're, have a furrowed brow, that they're maybe breathing more rapidly, that they're kind of kicking their legs, but they're curled up into, more of a fetal type position.
Right.
We want them comfortable.
Yeah. Our second topic that we're going to discuss with is not tolerating. That, that word we hear, not tolerating the medications. People may not think that that's a big deal, but for us it is.
Yeah. You don't want so many side effects. They don't want to take a medication.
There's a variety of reasons as to why patients don't tolerate the medications, right? For example, patients could have underlying allergies to the medication, so that could be why the patients stop. Our body size could change. So like Dr. Bohn was saying earlier, our body composition changes, so the absorption of the medication changes. Genetics, again, plays a role in that. And then also the presence of underlying diseases. The diseases could worsen to the point where it's not beneficial to take those medications.
Are we getting drug-drug interactions where these two medications don't agree with each other, and so one of them causes a little bit of nausea and the other one causes a little bit of nausea, and the two together make it just so the patient can't tolerate it? So sometimes we need to look at what that side effect profile, and not every person has read the book. So the book says this is how the patient's going to respond, but sometimes patients don't respond the way that the book says they are. For instance, I had a patient one time, and she was probably early 60s, and she came into my office because she recently had a small heart attack. It had not been a major incident, but she did have to get a stent placed. And the cardiologist said, you really need to be on this beta blocker. And so he put her on one, and it was giving her side effects of depression, pretty severe depression in just a few weeks. So she'd been discharged from the hospital. She had a 2-week follow-up with me, and she could already tell. She said, I feel like there's a cloud over me. I don't want to take this medicine. It makes me feel really bad, and not like sick bad, but mentally makes me feel bad. And I said, you're on the lowest dose there is. I'm going to have you stop it. Come back and see me in a week. You're supposed to see him in 2 weeks from now. I want to see you next week, and we'll see what your blood pressure's doing. She came back to see me in a week. She said, I already feel better. That cloud has
Wow.
lifted from me. And I said, then stay off your medicine and go to the cardiologist and tell him, how you feel. And so she went, and of course he said, nope, you got to take that medicine. You really need to be on that medicine. You've had a heart attack, so you got to take that medicine. So she went home, started on the medicine. She came and saw me a week later. She goes, Dr. Bohn, I cannot take that medicine. You just don't know how bad it makes me feel. And I said, I want you to stop it again, and I'm going to call him. And so I called him, and I said, it makes her feel really bad. He goes, oh, yeah, okay, well, have her come and see me. So she went down there to see him, and she told him, I'm feeling better off the medicine. He goes, yeah, but you've had a heart attack. And she says, wait a minute. Dr. Bohn said, I need to explain to you just how bad it makes me feel. She said, when I get home from work at night and I close the garage door, I don't want to turn the car off.
Wow.
And he said, oh, then don't take that medicine. So we need to know if you're having a side effect and how bad that side effect is so we can make a collaborative discussion and decision about what's appropriate for you.
And also know that if you're having these symptoms, don't just take it at face value of what the physician's saying. Advocate for yourself. I mean, when we're talking about symptoms of nausea, vomiting, increased confusion, hallucinations, some people get abdominal pain. They will have this horrible dry mouth, diarrhea, and some medicines cause a cough. I mean, these are things that are very disruptive. I had to.
You can't sleep at night because you're coughing.
You can't, and the dry mouth can be horrible. In hospice setting, we use the patch that's called years ago a scopolamine patch to help with secretions. When people are dying, they get more secretions in their chest, and it's caused the death rattle. Well, I went on my first cruise, and I put, I was like, big shot. Let me throw my scopolamine patch on because I get seasick. Well, I will never forget the first night on the ship. I woke up in the middle of the night, and I couldn't breathe because my mouth was so dry. And I ripped the patch off, and I was like, oh my God, within hours I started to feel better. But I actually was almost having a panic attack.
I felt woozy when I wore scopolamine patch.
Really?
It was for the same thing. I just kind of woo.
Well, I was dopey. I thought this is how you feel when you're on a cruise. It made me so miserable for the first 24 to 48 hours of my 7-day cruise. I thought I was not going to be able to go on a cruise. So it's just important to advocate for yourself. If you know your body better than anyone else, and you should make sure that you're advocating for yourself.
Mm-hmm. Let's talk a little bit about tolerance.
Yeah.
Is tolerance the same thing as not tolerating?
No, tolerance is really, by definition, it's a condition that occurs in the body as we get used to medication. So as we get used to medication, you either need more medicine to manage the symptoms, or in some cases, doing the more medicine gives you the double effect. Like we said, the side effects are worse, so we need to change medication. Mm-hmm. So it's not the same as not tolerating. It's a different category altogether.
And sometimes tolerance isn't a bad thing.
Mm-mm.
They may start you on a medicine. There's a medicine that we use for people with like the pins and needle sensation in their feet, and one of the side effects is it makes them drowsy. And so we'll start them on a low dose. We'll start them at bedtime, and then they say, oh, it's not making me so drowsy anymore. Then we may give them a little higher dose at bedtime. And then we'll work our way actually backward around the clock so that as they learn to tolerate that side effect and they're not made as drowsy, then they can actually take more medication to help eliminate that. Pins and needles, creepy crawly, I think they had a commercial that they ran for a while. It showed either like bees or ants on their feet. I'm glad they took that one off the TV because that was kind of creepy. But if you can't tolerate the medicine, you may be able to get to where you could tolerate those side effects. Mm-hmm. So tolerance can be, meaning it can refer to several different things about the medicine.
Right. Our third dreaded medication statement is third line treatments. A lot of times patients are told, okay, we've done the first line, that was not effective. We've done the second line, still not getting the right results, so let's go third line. When I think of third line treatments, I think of our cancer patients, usually chemotherapy. And this means that the treatment failed.
That's a dirty F word.
Mm-hmm.
Yeah.
It really is a dirty F word because it's important to recognize that This is because your loved one is very ill, and when both the first line and the second line fail. And then you have to also know that sometimes the third line isn't as good. Right?
Yeah, or the third line has a lot of side effects.
Mm-hmm.
And we want to point out that it's the medicine that failed, not the patient.
Yes, that's so important.
Mm-hmm.
I think sometimes our verbiage and the way we talk to patients is so important to the psyche, because
Mm-hmm.
if we use negative connotations, they feel like it's them, the person.
Yeah, I didn't do well with that, or I couldn't tolerate that. No, the medicine was harsh.
Mm-hmm.
And the medicine had a lot of side effects. You couldn't handle the medication, and it's or not because there's something wrong with you, but sometimes these medicines just are not something that people can easily take and get through.
Exactly. So to summarize today's topic, we just want to let you know that we hope this video helps you understand and appreciate the dreaded medication statements. We hope that you are able to learn from this and be able to advocate for both yourself and your loved ones if you're ever presented with any of these statements. Always make a list of questions to ask your healthcare provider, even if it's in real time. Sometimes, I'll hear from patients saying, oh, well, they told me I've asked too many questions, I have to save it. Well, then make sure you make a follow-up appointment pretty quickly, or call to speak to their nursing team.
Mm-hmm. Communicate with them, ask them the hard questions about the medication, and talk to them about what quality means to you. If tolerating a side effect is going to make quality not so well, it is your disease, it is your life, it is your quality of life, and we shouldn't be making those decisions for you and trying to guide you into something that's not acceptable for you. But we do want you to understand that we're concerned about your illness, that it has become serious, and we want to make sure that we care for you in the way that you want to be taken care of.
Yeah, and we love loaded questions, Dr. Bohn and I. When the family asks, what would you do if this was your relative? This is a good question.
It really is, and I think it's a fair question.
Mm-hmm. So please ask those questions.
One other comment that I had is sometimes a physician will tell a patient, you need to take this forever. And we get those
Another
comments.
F word.
Yeah, what do you mean forever? Forever's 5 years and forever and ever 7, 10. So, these medicines and our health is dynamic and changing. We may not need to take it to the very end of life. It may not be the best choice. So we really need to be open-minded about how long we're going to take those medications.
Yeah, and for all you that are healthcare providers, just watch your language and the way you speak to the patients, because you have the rapport as a primary care physician with your patient, and they are going to believe they're forever. And then when there's people like us that are coming in as the palliative medicine team that can see that the medication is causing more harm, it is very hard to get patients to stop them.
So in summary, this is a video about medications and how medication changes may indicate that your illness has become more serious.
And we would just like to empower you all with the information that you've gained. Please add any comments in the comment section, or send us any emails if you have any questions. We'd like to hear from our viewers of what you hear when you go to physicians' offices, and just know that we're here to support you, and we hope that all this information we're giving you will help you become and make powerful and educated decisions for your loved ones.
Thanks now.
Thank you. Bye-bye.